Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Robert Boutin, professor of radiology at Stanford, and he'll be discussing with us his recently published AJR article having to do with the imaging of sarcopenia. Dr. Boutin, thanks so much for joining us.
Great to be with you.
So this study is all about sarcopenia assessment on CT, which is commonly done using the SMI, or skeletal muscle index. And the premise of the article is that SMI is conventionally calculated as the skeletal muscle area, or SMA, raised to the power of 2 within its formula. And in this article, you challenge that conventional notion. So what gave you the idea of even just questioning whether 2 is the correct power?
Well, it comes down to a principle that's been known for hundreds of years among biologists, that of allometry. It's a term that we haven't heard much in radiology, but it just refers to biological scaling, the size and shape of living things. So, for example, in this case, how much muscle is normal relative to the size of the entire body, since you might expect that larger, taller people would have normally more muscle than small people. So given that we usually want to measure the size of muscle to evaluate for imaging features of sarcopenia, the conventional method is to take a cross-sectional area, for example, at L3, and then try and do some scaling based on how tall a patient is. And the conventional way that's been done thus far is to scale by height in meters squared. And people are probably familiar with body mass index, kilograms of weight scaled for the patient's height in meters squared. And it's the same sort of principle. For 20 years or so now, people have used this scaling factor of 2 when they measure the cross-sectional area of muscle, actually dating back probably to a paper in 2008. And 2 recent smaller papers questioned whether 2 is really the optimal scaling power. We have large resources at Stanford for automatically evaluating CTs, and we thought we would test out in our large patient population whether the scaling power of 2 to calculate a skeletal muscle index based on the cross-sectional area of muscle that we measure on a CT and the patient's height, whether the scaling power of 2 that's usually used is correct, or whether we should actually reconsider that scaling power.
So in your analysis, you had about 16,500 patients from your hospital who underwent abdominal CT within the study period. How did you measure the skeletal muscle area in those cases?
So with artificial intelligence now, one can automatically segment tissues, including muscle, in addition to automatically finding the right level for segmentation. So we have an open source tool that anybody can download at GitHub. It's called Comp2Comp. It's for computed tomography to body composition, Comp2Comp. It's free, it's open source. There are many other tools out there, but this is just the one that we use at Stanford. And essentially, you can feed in the CTs, and rather than manually segmenting muscle after finding the L3 slice, you can let the algorithm find the correct slice and then automatically measure the cross-sectional area of the muscle at that level. It turns out that this algorithm now does it from T12 to L5 and can also segment other tissues like visceral adipose tissue, subcutaneous adipose tissue, and bone.
So your large sample, you divided this into 2 groups, a group of about 5,500 patients for first coming up with an optimal scaling power, and then the group of around 11,000 remaining patients for then testing it and comparing it with a conventional power of 2. So can you describe for us how you divided it into the 2 groups?
So one of the amazing things that they also didn't teach me in medical school, besides not teaching me about artificial intelligence, was they didn't teach me about the electronic health record and now how algorithms and data scientists can go through the electronic health record in a very efficient big data analytics kind of way. So, of course, most patients coming in getting a CT scan have some comorbidities, and some of these comorbidities may affect the expected muscle mass. So what we did was we found all the list of ICD-9 and ICD-10 codes of patients who had conditions in their medical record that indicated they might be at risk for decreased muscle mass. And they're listed in detail in the paper, but essentially we took those ICD-9 and ICD-10 codes, and those patients who had major medical conditions, we excluded from our analysis to come up with a reference population of about 5,500 patients who didn't have major medical conditions. And to simplify things even further, focusing in on the patients who were up to age 40 gave us a subpopulation of patients getting CT scans at our institution who would have expected to have pretty normal muscle mass. And therefore, we could identify the optimal scaling power when we do the skeletal muscle area, cross-sectional area at L3, and what power that should be adjusted for with respect to the patient's height.
So to find the optimal power in that initial group of 5,500 healthy patients, you actually did a variety of statistical tests, and you performed these separately in men and in women, and in patients younger than age 40 and over age 40. And you had said up front that you would, from all this, find an optimal power to the nearest integer, just for clinical practicality. And all these different tests kept giving numbers around 0.97 to 1.1. So you end up settling on an optimal power of 1 for further testing. So let's just talk on one of those tests. So one of the tests you ran was the allometric analysis, and you mentioned that word earlier. How did that allometric analysis work to give you an optimal power?
So the allometric equation that's listed in the article estimates the skeletal muscle area as a function of height and age. And we fit this equation using a log-log transformation to give a linear regression. And so there's a lot of mathematics involved that if people are interested, they can read about the details in the paper. But what's important is that the skeletal muscle index that we came up with the optimal scaling power is independent from height, because we don't want someone to be at higher or lower risk because of their height. We want to find out what scaling power works regardless of height. So to emphasize the importance of this, we refit our height power, optimizing directly for height independence mathematically. And so the calculations are all listed in detail in tables and figures in the paper. But we arrived at similar height powers using these different methods. And we were actually open to finding something, a number that wasn't so close to 1, but it actually worked out beautifully, because with these different ways of analyzing things, the typical scaling power was actually very close to 1 for men and women, and even different ages, and definitely not close to the usual standard traditional scaling power of 2. So if you use the power of 2, taller people are going to be overpenalized for their height, and that's going to lead to an overdiagnosis of sarcopenia based on CT metrics with the old way of doing things.
And then in the final part of the analysis, you tested that, and this was in the about 11,000 patients with comorbidities who you had set aside at the beginning, and you compared in that group the ability to predict all-cause mortality using SMI when calculated using the optimal power of 1 that you found, or the conventional power of 2, and you use the concordance index as your measure of how successful that prediction was. and you found that the concordance index was a bit higher using the power of 1 than of 2. So then you concluded that that was the power that you recommend. What are the implications of this for readers? What should we do with this information?
So although the concordance indices were close, the difference was highly statistically significant. So I think it came out that this really is a powerful case for 1 being much better than 2 for scaling of height when looking at a cross-sectional area of muscle at L3. The reason we did the survival analysis is I'm just a simple clinical radiologist, and in addition to doing these mathematical calculations, I wanted to see what happened with a very binary dichotomous outcome that we all care about, mortality. And so we had those data and did the analysis, and so those outcomes you just summarized very nicely. So I think going forward, what this means is that we should reconsider how we typically characterize muscle mass opportunistically on CT scans. That's most commonly done at the L3 level. And these findings are relevant for cross-sectional areas at L3. But I would hasten to add that if we segment a volume of tissue, a volume of muscle, that the scaling factors might be very different. It might scale to the power of 2. But the sort of essential insight of this paper was that if we're doing a cross-sectional area in 2 dimensions rather than a 3D volume, we need to scale differently for patients' height, whether they're tall or short, because it will matter in how they get classified in terms of whether they have muscle depletion or not.
Great. And any closing thoughts for us?
I think it's just an exciting time, this field of opportunistic imaging and sarcopenia. They're both quite new. And so I think they're early days. And so a lot of progress has been made in a short amount of time, but I think it's just the beginning. And so I'm looking forward to reading future articles in AJR and learning where this field goes.
Dr. Boutin, thanks so much for coming and sharing your insights with us.
Thank you.